Our next speaker is Dr. Holly Konciki, and she is a professor at Mount Sinai Hospital. She received her MD from Rutgers, New Jersey Medical School, and followed up by her residency and the nephrology fellowship at Mount Sinai Hospital. And currently she is an assistant professor, and she was dual appointed at Department of Nephrology and Department of Geriatrics and Palliative Care. She also directs of the Integrated Nephrology Palliative Care Medicine Fellowship. She's an expert in communication skill and symptom management in patients with kidney disease. Welcome, Dr. Konciki. Thank you so much for this, to give us this important talk on pain management in CKD patients and ESRD patients.
Thank you so much for having me today. So today's session is entitled Identification, Exploration, and Expectations, a Team Approach to Pain Management in End-Stage Kidney Disease. My only disclosure is I receive an honorarium for up-to-date authorship. And at the end of this session, I hope that you will be able to describe the concept of total pain and understand how it can impact the treatment plan. You should be able to describe a general approach to pain management, to recognize medications which are preferred for use in patients with end-stage kidney disease, and to be able to identify patients who may benefit from referral to either pain management or palliative care. And I want to start by introducing you to Lisa. Lisa is a 50-year-old female with end-stage kidney disease on hemodialysis for the last 6 years. She has secondary hyperparathyroidism, diabetes, hypertension, and peripheral vascular disease with a below-the-knee amputation. When you round on her at the dialysis unit, she looks down and describes that she feels like she was robbed of her limb. Additionally, she has severe joint and back pain that has been attributed to renal osteodystrophy. This pain impairs her ability to carry out some of her activities of daily living and her ability to work. Furthermore, she cuts her treatment short at least once per week. Because of this, she often does not meet her dry weight, and she's had several admissions for fluid overload. Her primary care doctor asks that she follows back up with the nephrology provider to help manage her pain. Now, patients with chronic kidney disease and end-stage kidney disease have a symptom burden comparable to that of patients with other serious chronic illnesses, including malignancy. 50% of patients with end-stage kidney disease will have chronic pain, which is pain defined as pain lasting for at least 90 days. Regardless of the modality of end-stage kidney disease treatment, whether it's hemodialysis, peritoneal dialysis, or conservative care, this prevalence of chronic pain appears similar. Additionally, these patients rate it as moderate to severe in intensity in 80% of cases. So what is causing the pain? 20% of the patients will have more than one cause of pain, but most commonly, musculoskeletal cause is the most common. Now, our ability as providers to assess and treat pain can impact the healthcare of our patients on numerous levels. On a patient level, we know that untreated pain has been shown to negatively impact their quality of life. These patients have higher rates of depression, insomnia, an inability to cope with stress, an increased perception burden of disease, a decreased perception of social support, and decreased overall life satisfaction. From a dialysis perspective, dialysis patients who have untreated pain have an increased number of shortened or missed treatments, increased hospitalizations, and increased utilization of the emergency room, and are more likely to withdraw from dialysis. From a healthcare system standpoint, it's estimated that chronic pain costs the United States billions of dollars annually. One study I read estimated $600 billion annually, $300 billion in healthcare spending, and another $300 billion in lost productivity. So how are we doing? We underreport the majority of symptoms that our patients experience. When pain is identified, it's underestimated in 63% of cases. And in fact, patients with end-stage kidney disease that report moderate to severe pain that interferes with their ability to work say that their pain is undertreated 74% of the time. So why is this the case? I think there's a number of barriers and misconceptions on both the patient level and the provider level. So from the patient level, in the media, we're seeing often news reports about celebrity deaths from prescription overdose. And, patients are sometimes scared and hesitant to report pain because they are worried about the effects of these medications and the potential stigma that might be associated if they are taking opioids on a regular basis. From a provider standpoint, though the majority of nephrology providers report that they feel comfortable prescribing pain medications, only 40% do so on a regular basis, and less than 50% have had education regarding pain management during their medical training. Additionally, we're concerned about polypharmacy in our patients, as our patients take upwards of 10 different medications a day. There are misconceptions that exist. Some may say that pain is more difficult to assess and treat in patients with renal disease, and this is not true. Others may say that pain is a normal part of aging and of dialysis, and that's also not true. And other providers may say that it's not my responsibility. And I would argue that even if you do not feel comfortable prescribing pain medication, if you identify pain in your patients, then you should refer to the appropriate provider. So how can we approach treating pain? We should assess pain, follow recommendations by the World Health Organization analgesic ladder, set up expectations of treatment, provide follow-up, and monitor for side effects. Now, I want to introduce this concept of total pain. Pain does not exist in isolation. Rather, pain can affect other aspects of the patient's life, including their psychological well-being, their social aspects of their social life, and spiritual pain. And this is where dialysis patients have an advantage in that they have an interdisciplinary team that helps to care for them. And I would really say that the interdisciplinary team can take a large role in assessing the total pain of our patients. The nurses, the dialysis techs, the social workers, and the providers in the dialysis unit. So for example, Lisa has physical pain in joint and bone pain. And this is what the pain medication would target. But we know that this pain can affect her mood. She feels robbed of her limb from her amputation, and her mood is down. Now, both this pain and this low mood can affect social aspects of her life. The pain is inhibiting her ability to work. That leads to a loss of finances, and that can drive to her having anxiety about finances and financial stress, leading to further psychological pain. Additionally, if her social support and her social network was from work, now this is also going to be impeded upon. Lastly, from a spiritual aspect, she may have anger and may search for meaning as to why these things are happening to her. We find that chronic pain and depression coexist in upwards of 70% of patients. Chronic pain, as I said, can lead to low mood and changes in socialization, and depression can worsen the perception of pain and also lower the pain threshold. So again, a role for our interdisciplinary team is to screen for depression. And if someone screens in as potentially having symptoms consistent with depression, then the nephrology provider should decide on what the next best steps should be. And I can't highlight this enough. As with any other symptom that somebody may have, when someone has pain, it's very important for us to determine what is the underlying cause of that pain and not to just treat with pain medication. So another role for the interdisciplinary team is to take a targeted pain history and physical. Now, a mnemonic that is often used is PQRST. So we want to ask what the precipitating and palliating factors are of the pain. What makes the pain better? What makes the pain worse? What pain medications have you tried in the past? What has worked well for you and what has not? The quality of pain. What does the pain feel like? Is it a burning sensation, suggestive of neuropathic pain, or a throbbing sensation, consistent more with nociceptive pain? Where does it hurt? Is it localized to one spot, or does the pain radiate throughout other parts of the body? And as pain is very subjective, having them rate pain in terms of severity on a scale of 1 to 10. Lastly, the timing. When did the pain start? Is it constant or does it come and go? Identifying the chronicity is also very important. Is the pain acute, for example, from trauma or from surgery, and we expect that the pain will improve over a period of days to weeks? Or is this pain chronic and we expect the pain to require treatment with medications for more than 90 days? Lastly, is this pain that someone is experiencing towards the end of life in which other symptoms may start to develop? Lastly, we want to figure out what type of pain is the patient experiencing. Nociceptive, which is a result of tissue damage, so example would be musculoskeletal pain or abdominal pain, or neuropathic pain, which is pain related to the dysfunction of either peripheral or central nerves. So having somebody say what the severity of the pain is can be very important because everybody will interpret pain and experience pain differently. Severe pain in one patient may be a 10 versus another patient may label that pain level as a 7. So it's important to use either a numerical scale saying something like from 1 to 10, with 10 being the worst, where do you rate your pain at its worst? Or a visual scale, which you can see in front of you, either with numbers or with a line. And I'm sure you've also seen the one with the different faces, which is actually copyrighted, so you can't show it during some presentations. But it's important to really assess pain at its worst, and then during treatment, see where the severity moves to show that there is some type of objective measure of this very subjective feeling. There are more involved pain surveys, including the McGill Pain Questionnaire and the Brief Pain Inventory. And this is used often in research, but in the clinical setting, it's not really realistic because it's very time consuming. So in terms of our approach, we want to follow the World Health Organization's analgesic ladder. Now, this is the ladder. It provides a framework to help us in making decisions about what medications to prescribe and when. It is based upon severity of pain. So to briefly walk you through it, step 1 is for mild pain, and the recommendation is to use non-opioid analgesics, including non-steroidal anti-inflammatories or acetaminophen. Step 2 is for moderate pain. And what's described in the treatment ladder is to use weak opioids. Though I don't particularly agree with this nomenclature, I don't think there are weak and strong opioids. Rather, I believe that it's just a spectrum of dosing. And then step 3 would be for severe pain. So using higher doses of the opioids or some long-acting medications. Step 4, interventional therapies. Now, this ladder has been validated in studies looking at patients receiving hemodialysis, and it is effective. That being said, there are limitations to this study or to this framework. The first is that it's not looking at the total pain concept. It's not taking into account mood and other factors that might help the patient's total pain experience. Secondly, it's based upon severity. If we base our pharmacologic dosing upon severity, then we're going to be giving lots of patients opioids. And the literature and the evidence behind opioid efficacy in treating chronic pain is rather limited. And with the ongoing opioid pandemic, there is concern about using opioids in a safe manner. Thirdly, this is only for nociceptive pain. It does not include neuropathic pain in which different medications would be given. And lastly, I would argue that the step 4 should actually be moved more upstream, and that if there is an interventional procedure that could be done, that should be tried first in order to save patients an additional pill burden of a systemic therapy. Now, non-pharmacologic therapies, there is limited evidence in its efficacy in our patients with end-stage kidney disease. Though evidence is limited, the side effects are really minimal, so it's worthwhile trying these if patients are amenable. So you can use cold or heat to bring down inflammation, exercise and physical therapy for musculoskeletal pain, music therapy, massage, acupuncture, and cognitive behavioral therapy. Again, all have some evidence of efficacy. The only limiting factor is how accessible these really are to patients. Localized therapy can be very effective. So for example, if someone has mostly shoulder pain in one area, you can try some of these topical agents. A lidocaine patch is put on for 12 hours and then off for 12 hours. It works by inhibiting sodium channels, which inhibit the propagation of pain sensation. Capsaicin cream is often used for neuropathic pain, usually in conjunction with some type of systemic therapy. It works by desensitizing nerves and also decreasing nerve fiber density. Low-dose creams are available over the counter. Higher dose patches are being investigated and show some promise, though not FDA approved. There was a study, in fact, of 20 patients with end-stage kidney disease in which a higher strength patch was put on for 60 minutes. And following that one 60-minute application, patients had pain relief for up to 3 months. And in fact, they had a reduction in their systemic opioid use by 50%. Sounds really promising, but there are some limitations and contraindications in its use, including uncontrolled blood pressure with a systolic blood pressure over 200, as well as a cardiac event in the 3 months preceding use. So that may be limiting in our population. Lastly, topical NSAIDs have been shown to be effective and reduce systemic NSAID use by 40%. For pain related specifically to cannulation of the access, I'm sure many of us are familiar with the lidocaine prilocaine creams, which need to be put on for about an hour before cannulation, or the ethyl chloride vapocoolant spray, which you can use seconds prior. Moving on to our systemic therapies, step 1 is our non-steroidal anti-inflammatories. Now, the American Society of Nephrology and the ABIM's Choosing Wisely campaign states that we should avoid using NSAIDs in certain disease states, including hypertension, heart failure, and chronic kidney disease. In fact, they go as far to say that short-term use of narcotic analgesics may be safer than and as effective as NSAIDs. So this places providers in a bit of a bind. We have this pressure of the ongoing opioid epidemic, and we are encouraged to use opioids less. But then our non-opioid alternatives, we are being told to avoid use. So what exactly is the concern around NSAIDs? Now, in patients with advanced chronic kidney disease who are not yet on dialysis, the concern is that it will expedite the renal function decline. For patients on dialysis, the data is limited, but some general concerns include changes in blood pressure. In population studies, up to 23% of patients without previously diagnosed hypertension who are started on NSAIDs will develop new hypertension. For patients who have underlying hypertension, 30% will require an adjustment in their medications after starting NSAIDs. Now, this appears to be somewhat related to the antihypertensive medications they're on, as patients on ACE inhibitors have a 10% increase in blood pressure compared to patients managed on calcium channel blockers that have only a 1% increase in their blood pressure. 7% of patients who start NSAIDs will have evidence of volume retention, though that study did not stratify based upon renal function. And specifically in end-stage kidney disease, there is a study describing a 31% increased risk of stroke in the 30 days following NSAID use. So what are the recommendations? So it's going to depend upon the provider. I'm a little bit more liberal with use of NSAIDs in the appropriate setting. You can use it for a short-term course and monitor closely for blood pressure and volume status. And you want to make sure they have no other contraindications like peptic ulcer disease and a recent gastrointestinal bleed, which NSAIDs would put you at a further increased risk of. The non-opioid drug of choice is acetaminophen. The max dose is 4 grams per day due to concern of liver toxicity. And some sources will cite increasing the dosing interval from every 4 to 6 hours to every 6 to 8 hours, though the evidence behind that is really lacking. So next, we want to set expectations of treatment. So we want patients to understand that they will not be pain-free. Rather, we want to find out what level of pain is acceptable to them and aim to get to that level. And that level should be that they are able to do activities which are important to them. They will have improvement in their quality of life. And we want to set a duration of therapy. So we'll follow up in 1 or 2 weeks. For Lisa, the goal is to complete dialysis treatments, and she really hopes to be able to go grocery shopping, clean up around her home, and she knows that she will not be pain-free. We decided to start acetaminophen 1,000 milligrams every 8 hours around the clock, and we avoided NSAIDs because of her frequent admissions with volume overload. A week later, she's feeling a little bit better, but she says, is there anything else that we can try? The next decision point is, should we start an opioid or should we refer to a pain management specialist? And this, again, is going to be really provider dependent. Some questions I think could be helpful to ask is, 1, is this acute or chronic? If this is pain that we think is going to improve in days to weeks, then perhaps some would feel comfortable prescribing an opioid. Rather, if this is chronic pain that may potentially be lifelong, and they would need medications for that period of time, then some providers might want to refer. Second, what is the patient's prognosis? If we expect the patient's prognosis to be limited, then Perhaps referring to palliative care would be helpful to address other symptoms and other advanced care planning. Lastly, is this patient at risk for aberrant behaviors, abuse, or addiction? And there are several validated tools that can be used to identify patients at risk. And this is another area where I think our social workers, can be very helpful in screening patients. And if they do screen in as being potentially at an increased risk, referral may be appropriate. So in terms of medications to avoid, these recommendations are based mostly upon pharmacologic data and case reports. We should avoid morphine, codeine, hydrocodone, tapentadol, meperidine, and extended release tramadol. Now, for example, morphine is metabolized into an active metabolite called morphine 6-glucuronide. That metabolite is renally cleared, and in patients on dialysis who are given morphine, we find that this metabolite is present in their cerebral spinal fluid at a level 15 times that of patients with normal kidney function who receive morphine. So there are case reports of morphine causing central nervous system depression, respiratory depression, myoclonus, and death in our dialysis patients. And all of these medications have similar pharmacologic pathways and metabolic pathways. So what are the preferred medications? So preferred medications are oxycodone, hydromorphone, and short-acting tramadol. Now, oxycodone and hydromorphone are both dialyzable. Tramadol is not. Therefore, tramadol has a really strict dosing guideline of 50 milligrams every 12 hours as the maximum dose. Whereas oxycodone and hydromorphone, there is no real max dose. It's dependent upon how a patient tolerates the medication. For long acting, there is methadone, which you need extra education to prescribe. So if methadone is being given, you would need to refer out, and a transdermal fentanyl patch. You would never use a fentanyl patch for acute titration. Rather, once you have somebody on a stable dose of, say, oxycodone, you can then convert that into an equivalent dose of a fentanyl patch, and then they can use that every 3 days to give some more long-term relief. So for Lisa, we decide to start with a short-acting medication because it's easily titratable. So we decide to give oxycodone 5 milligrams every 6 hours as needed. We want to avoid using combination medications. So for example, oxycodone comes in a combination pill with acetaminophen, commonly, trade name is Percocet. We don't want to use Percocet to titrate up her medication to see what dose she will be, what dose will be effective for her, because the acetaminophen will be capped at 4,000 milligrams per day, and therefore we're going to be limited. So rather, we're going to keep her on the acetaminophen, 1,000 milligrams every 8 hours, and then we can dose the oxycodone and adjust the dose of the oxycodone as necessary. When we follow up, we will adjust that dose if she's still having pain that is moderate or severe in intensity. We also want to evaluate for side effects of these medications before up titrating. So we follow up with Lisa 2 weeks later. In terms of her pain characteristics, she says the pain is not as bad once she takes the oxycodone, and she has not cut any treatment shorts. In terms of severity, her pain went from an 8 to a 10 to a 3 out of 10 with the medications, which is tolerable to her. In terms of how she's been using the medication, she's been taking the medication every 6 to 7 hours while awake, but notices that after 5 hours, the pain starts to increase. In terms of side effects, she notes that she felt a little sleepy the first hour or two after taking a dose for the first week, but that got better. However, she does endorse that she has worsening constipation since starting the medications. So in terms of side effects to monitor for and to discuss with patients prior to prescribing, drowsiness is very common, but will improve with time. So the longer you take the medication, the drowsiness will wear off. Constipation is something that will not wear off. And it's estimated that for patients receiving opioid medications for non-cancer related pain, 40% of patients will have opioid-induced constipation. So when you are prescribing opioids, we need to be counseling on lifestyle modifications, such as increasing fiber. And also, usually it's recommended to prescribe a bowel regimen. So giving senna or polyethylene glycol along with the opioid to help prevent this from occurring. Lastly, pruritus is very common. It can get better. Sometimes it does not. So if it does not get better, you would consider rotating to a different opioid medication. So several months go by, and at that point you're rounding, and Lisa notes that she's having this worsening burning sensation in her left foot. It was there before, but it's getting better. So now she's complaining of more of a neuropathic pain. So our first line agents to treat neuropathic pain are gabapentin and pregabalin. Now it's important to note that only pregabalin is FDA approved for diabetic neuropathy and post-herpetic neuralgia. When gabapentin is used to treat diabetic neuropathic pain, it is being used off-label. And we see that gabapentin and pregabalin are used off-label in our patients with advanced kidney disease and end-stage kidney disease often to treat neuropathic pain, pruritus, and even restless leg syndrome. But it is important to share this information with patients when we are prescribing. So what we know is that these medications are renally excreted. Toxicity of these medications include lethargy, dizziness, and myoclonus. Studies show that patients are at risk of falls, altered mental status, and fractures with increasing doses of these medications when patients are also receiving dialysis. What is not really clear is how these medications behave in dialysis. We know that they are somewhat dialyzable, but there's really no studies regarding pharmacokinetics according to dose. So all recommendations are based upon expert opinion. So in terms of the dosing guidelines, it will vary based upon provider experience and comfort. We recommend starting low and titrating slowly. For example, we would start dosing just after dialysis every other day, evaluate a week later, go up to daily, evaluate a week later. If more medications is needed, then you can up titrate the dose from there. Gabapentin, the maximum recommended dose is 300 milligrams daily in patients receiving dialysis, and pregabalin is 75 milligrams daily. Okay, so for conclusions, an approach to managing pain includes taking a pain history, setting expectations, and providing adequate follow-up. Total pain is best evaluated through an interdisciplinary approach. Preferred medications for opioids include hydromorphone, oxycodone, and tramadol. Gabapentin and pregabalin for neuropathic pain, though they are used off-label. We want to start low and titrate slow, and ensure that we are monitoring for efficacy and side effects. I thank you for having me today, and I'm open to answering any questions.
Great, thank you so much. We have a question from Dr. Saeed. What is your approach? What is your approach toward people who has whole body pain already on duloxetine, antidepressant, Tylenol, and other non-opioid meds?
You mean that they're already on those medications?
Right, correct.
I mean, I think that really doing that total pain assessment can be helpful. So evaluating for concurrent depressive symptoms, really evaluating other aspects of the life that might be contributing to the pain, and really taking a thorough pain history in regards to total pain. So, you know, what does the pain feel like? What is making it worse? Because I think that that can sometimes provide an opportunity to see, you know, in what areas we can focus our attention more on.
Now, I have a question on residual kidney function with NSAIDs. We always worry about, using NSAID knock out residual kidney function. I'm a bit surprised you use it in some of the patient. How do you manage that?
I mean, I think it all has to be, again, risks and benefits. So I think that depending on how much residual kidney function there is left, the decision to start a short course of an anti-inflammatory versus placing the patient on an opioid medication when they may already be on other medications like antidepressants or gabapentin that could be potentially sedating and put them at increased risk of outcomes like falls and hospitalization. You know, it needs to be an individualized decision and a discussion with the patient. But I find that a lot of patients are, more amenable to the anti-inflammatories, and that the anti-inflammatories actually work well to bring down inflammation, musculoskeletal pain, rather than the opioid medications.
Okay. One more question. What about TENS, TENS?
Yeah, so there is like some evidence regarding using TENS therapy, which is like electrical like stimulation to help with musculoskeletal pain. I think again that a lot of the alternative therapies, which there are a lot of and definitely worth exploring, the only limitation is really how accessible those therapies are to patients. Sometimes financially they're not accessible. Sometimes, to find someone nearby that is able to provide that might be difficult.
Great. Thank you so much. It's wonderful talk, very helpful, helpful suggestions and recommendations. Hope to learn more from you.
Thank you for having me.